So, good afternoon, everybody. This webinar is on inflammatory myopathies, and my name is Olivier Benveniste. I'm professor of internal medicine and clinical immunology in Paris at the Pitié Salpêtrière Hospital. I run the Myositis Center in Paris, which is the only one in France, in fact. And also, I'm the head of one team of research on inflammatory myopathies once again. So I will try today to show you that it's very important to classify properly the patients because the physiopathogenesis of the different subgroups of myositis are really different, and we will have tomorrow a lot of different targeted treatments. So first of all, I don't know how to move forward. How can I? Okay, so you see my next slides? That's okay? Is it okay? You have seen my second slides?
Yeah, that looks fine, yeah.
Okay, perfect. So can continue. So just a few words regarding the past history of myositis. We started in the 19th century with two first description, first of all, of dermatomyositis by a French doctor, which it is in French, but if you can read, it's in fact a description of the heliotrope rash. And then the first time where polymyositis was used, it was also at the end of the 19th century by a German guy. And at that time, the photography didn't exist, but he can just draw what he saw on one of the first microscope. And you can see here the inflammatory infiltrates within the muscle. And we have to wait for 100 years with the first well-known classification of myositis done by Bohan and titer in the New England Journal of Medicine. Simply saying that if you have a myopathy with a symmetrical proximal muscle weakness, with some inflammation at the muscle biopsy, with high CK level, and myogenic electron EMG, then you have a polymyositis. If in addition you have the typical rash for dermato, then you have a dermatomyositis. But we have to wait for more than 20 years to have the first definitions of inclusion body myositis done by this group of experts in this workshop report. And we have to wait some, I don't know how much, but few 20 more years, roughly, to have this last definition of inclusion body myositis, which is the fact that if you have a finger flexor weakness and a quadriceps weakness, and when under mesial inflammations, that means inflammations within the muscle, and invited fibers, as you can see here, or the presence of rim vacuoles, then the probability to have an inclusion body myositis is very high. We have also one other subgroups coming in the beginning of the 2000s, which is the immune-mediated necrotizing myopathies, which this time is very similar to the polymyositis in the definition of Bohan Peter, but that time you don't have a lot of inflammatory infiltrates within the muscles, but mostly necrotizing fibers and regenerative fibers, as you can see here. And in parallel, years after years, in a research lab, was discovered some myositis-specific autoantibodies. The first one was in the mid-17th. It was isolated in Mr. or Mrs. Mitchell. That's the reason why it's called MI2, and it is specific of a certain subgroup of dermatomyositis. Second one was discovered in Mr. or Mrs. Jones, and this is anti-G1, and this one is specific to the AntiSynthetase syndrome, and so on and so forth. And you have some of them which are specific to immune-mediated necrotizing myopathies, other AntiSynthetase syndrome, and all this last one, MDA5, SAE, TIF1 gamma, NXP2 to dermatomyositis. And the last one was the anti-CN1A, was a little bit more specific for inclusion body myositis. So the problem was that during decades, it was difficult to fish these antibodies because it was done in lab, research lab with immunoprecipitations, meaning that you have to work for 3 days for, with radioactivity. And it's not very useful and convenient for the routine, the clinical routine. But much more recently came these commercial line-dot assays, which permit to have the results in roughly 2 hours. And then on one sample, in the context of one myopathy, clinical myopathy, you can have the result. This is 2 different brands, 2 European brands, in fact. And in the first example, you have a patient with antibodies directed against MDA5. So it's really a revolution because now you can have an access to these autoantibodies very quickly, rapidly in every clinical, immunological clinical laboratory of your hospitals. So what is the interest and the burden of these autoantibodies in the diagnosis is still a little bit debated in the field of myositis experts. And for instance, you can see on this relatively recent review that SRP are classified among polymyositis. MI2 is somewhere between polymyositis and dermatomyositis. And all the anti-synthetase autoantibodies are distributed between polymyositis and dermatomyositis. Furthermore, more recently, Ingrid Lindberg published this paper with a group of rheumatologists, and they obtained a huge amount of money from one European FP7 grant to revisit the classification of myositis. And they did it with modern statistical analysis on a group of roughly 1,000 myositis patients and 600 comparators with different neuromuscular disorders. We have no clear ideas of these comparators, and it might be one of the problems. And at that time, when they started this work, they have access to only one myositis-specific autoantibodies, the anti-G1, not all the other ones, not a dozen of other autoantibodies. That makes that at the end of the day, they don't have something really new since they just obtained 3 subgroups, the dermatomyositis, juvenile or not, the polymyositis, and the inclusion body myositis, with a sensitivity and a specificity not better than a previously published classification systems such as the one of Targov, for instance. And because it is modern, then you can have also the help of one algorithm online, and you just have to log on this website, and you answer these 13 different questions, and that gives you a probability to have one of these 3 subgroups against dermato, poly, or IBM, or to not have a myositis. So we play the game, and it's one ongoing work in my team. And for instance, 2 examples showing the limit of this algorithm. First, the first patient is 74 years old. He had a proximal and a distal weakness with a very easily diagnosis just with the phenotype of inclusion body myositis. As you can see here, he has this very classical feature with this quadriceps atrophy. And in the pathology ground, you can see these inflammatory infiltrates, which invade somehow one fiber here, but with no vacuoles, and it's frequent situations during IBM. So using this algorithm, you can have a good score with a high probability of polymyositis. If you are an expert, you can have a doubt and think that the phenotype of this guy is really of one IBM. But if you are not, and you use this tool, then you will conclude that it is one polymyositis. Then you will treat your patients with corticosteroids, and it's maybe not the best idea. The second example is this young guy, much more younger, since he is 20 years old. And he had a rapidly progressive weakness, proximal, but also distal. And with this biopsy, and you can see these little inflammatory infiltrates, but it exists. And the algorithm gives you the very high probability of a polymyositis. And in fact, it's one limb girdle dystrophy, muscle dystrophy, a dysferlinopathy, where it is known that inflammation is relatively frequent. So once again, it's a trap, and the problem of this kind of algorithms that it cannot permit you to avoid this kind of traps. So to put a little bit more burden on the myositis-specific auto-antibodies, we decided with the Kubiraka, this is a young girl here, to perform one study unsupervised, starting from our registry of patients. And we keep, at the end of the day, 47 variables, which are the description of the patient, their age, gender, race, but also clinical signs such as the skin rash, the distribution of the weakness, the pathology, description of the pathology, and at least all these myositis-specific autoantibodies. The lung involvement also, and so on and so forth. And with these 47 variables, we asked to the computer, with no supervision by the doctors, to clusterize the patients. And this is just one tool coming from the geometry. And you ask to clusterize the more mimicking patients. And you can observe that there are 4 subgroups. Once again, it's one unsupervised way to clusterize patients. And then you can ask to the computer which are the main characteristics of the different subgroups, those with the highest probability to fall in one of the 4 subgroups. And of course, you don't feed the computer with the diagnosis. You don't say to the computer that this is IBM and all the criteria, and then you ask, where are the IBM? No, you put all the parameters, and at the end of the day, you ask to the computer in which cluster fall the IBM. And here, IBM, inclusion body myositis, fall in the first cluster. And this cluster is characterized by the fact that we have more men and from Caucasian origin, few patients from African origin. These men are older than in the other group, over 16 years old. They have finger flexor weakness, quadriceps weakness, moderately elevated CK levels, and at the pathological ground, vacuolated fibers, invited fibers, and no skin, lung, joint lesions, nor myositis-specific auto-antibodies. The second cluster is the one of the immune-mediated necrotizing myopathies. We can observe more women, many from Asian origin, at least from the population around Paris. With, they are weaker in their psoas than in the upper limbs, with high CK levels. Here we found anti-SRP and anti-HMGCR clearly, and at the pathological ground, no inflammation, spherical perivascular atrophy, but in fact, only regenerative fibers and necrosis, and no skin lesions. The third cluster is the one of dermatomyositis with young patients. This time, the weaker muscles are the deltoids, and here you have all the skin rash, which is the heliotrope rash, as you can see here, the shoal sign, edema, skin ulcers, Gautron hands, Gautron papules, calcinosis, and so on and so forth. And here you can observe the specific auto-antibodies, anti-MI2, MDA5, anti-TIF1 gamma. In our cohort of patients, we don't have many other, for instance, NXP2 auto-antibodies. On the pathological ground, we can observe perivascular atrophy, perivascular infiltrates. And in this group is clearly the one linked with the presence of cancers, not the other ones. And finally, the fourth one, the last one, is the one of the AntiSynthetase syndrome, where we can observe more patients from African origin, young also, with mechanic hands, and these mechanic hands are not the typical rash of dermatomyositis. Is this hyperkeratosic, painful fissures, lesions of the fingers, interstitial lung disease in almost all the patients, Raynaud phenomenon, arthralgia, very high CK levels, and anti-G1 or anti-PL7 or anti-PL12. So that makes that, at the end of the day, this classification unsupervised is very similar to the one just by common sense we proposed by just the observation of the patients in 4 subgroups, the one of the dermatomyositis with all these specific autoantibodies of dermatomyositis, and cancers are associated with anti-TIF1 gamma and NXP2, as you know. The group of immune-mediated necrotizing myopathies with anti-SRP and anti-HMGCR. The group of what I call overlap myositis, overlapping with other connective tissue disorders features, such as the interstitial lung disease that you can observe during sclerodermia, but also arthralgia, Raynaud phenomenon, once again, mimicking somehow sclerodermia. And furthermore, we can observe some shared autoantibodies with sclerodermia, such as anti-RNP, anti-PMSCL, or anti-KIU. And in this subgroup, you can have the group, the subgroup of antisynthetase syndrome. And finally, totally separate, totally different, is the group of inclusion body myositis. If you come back to the classification of Bohan and Peter, you can see that polymyositis at that time regroups the antisynthetase, the overlap, the inclusion body myositis, and the immune-mediated necrotizing myopathies. And since the mid-19th, one group have published one paper saying that polymyositis is certainly one overdiagnosed entity, because in their cohort at that time, most of the polymyositis patients were patients with one other connective tissue disorder or inclusion body myositis. And the editorial associated to this paper said that polymyositis is a sort of mythological beast. If you use the ACR Eular classification, the last one, published one in 2017, then you still have this polymyositis group, which in fact is composed by the overlap syndrome and also the immune-mediated necrotizing myopathies, but also, of course, dermato and IBM. So now I would like to highlight the fact that the physiopathogenesis in this different subgroup is really totally different. And we will start by immune-mediated necrotizing myopathies with anti-SRP and anti-HMGCR. First of all, the target of these auto-antibodies is really within the cytoplasm of the cells, on every cell, in fact, because SRP complex permit the translocations of the nascent proteins after their synthesis to the endoplasmic reticulum. And HMGCR is the target of the statins, in fact, to permit the synthesis of the cholesterol. And once again, this protein is in the endoplasmic reticulum. But we observed first that there is a good correlation between the CK level, and the CK is just the reflect of the myelolysis. The more you have necrotic fibers, the more your CK levels is elevated. And the anti-SRP titers over time. You can see here 8 patients over time, where you can observe that at day 0, before any treatments, you have the level of titers of your anti-SRP and your CK levels. And other treatment, you can see the decrease of the CK levels, but also of the anti-SRP levels. And it's not a very frequent situation. We don't have so many connective tissue disorder where you can see this kind of correlation between the titers of the antibodies and a marker of the disease activity. And that's the same story for anti-HMGCR. You can see here another paper from our group showing in a cohort of anti-HMGCR positive patients, the correlation between CK levels and the anti-HMGCR titers. That makes that even back, this is this guy, ask if the antibodies by themselves are responsible of the necrosis. So to answer these questions, he first of all quantifies the number of necrotic fibers on patients with anti-SRP myopathies or anti-HMGCR compared to G1 on dermatomyositis. And you can observe that the necrotic fibers are randomly distributed within the endomysium of the muscles. And it is always perifascicular during anti-G1, that's not the same distribution. And you can observe that, once again, the number of necrotic fibers is correlated with the CK level. Then you can observe that you can see some deposit of C5b9. C5b9 is a membrane attack complex of the complement on this, decorating some muscle fibers, as you can observe here. And that's not the case during limb-girdle muscular dystrophy, where you can observe a lot of necrotic fibers too. And as you know, the complement can be activated by the classical pathway or by the alternative pathway. So to see which pathway is activated here, he did some staining with antibodies against C1q, which is the hallmark, the clear marker of the classical pathway. And the classical pathway is activated by immune complex between, for instance, a bacteria and one antibody. And here you can observe also on muscle biopsies some deposit of immune complex, of immunoglobulins at the surface, decorating some muscle fibers. And if we use plasmapheresis from very severely affected SRP or HMGCR patients, and from this plasmapheresis, we purified specifically the SRP or the HMGCR in a column charged with a recombinant SRP protein or recombinant HMGCR protein. Then we can also immunostain our biopsies by immunohistochemistry, showing some fibers decorated by the anti-SRP and HMGCR. So even if the target of these antibodies is at the cytoplasm level, we can observe some deposits of this anti-SRP or HMGCR at the surface of the muscle fibers, activated then the classical pathway of the complement, leading to the formation of the membrane attack complex that makes hole in the membrane of the muscle fibers, and which presumably is the mechanism of death of these cells. Furthermore, Louisa Rouche in our lab also performed some experiments with cell culture in vitro of healthy donors myoblasts that you can fuse to make some myotube. And if you add anti-SRP or anti-HMGCR, you can observe that we cannot have the fusions of the myoblasts to form the myotube because it blocks two very important myokines, IL-4 and IL-13. And also, if you add these antibodies to already formed myotube, then you induce one atrophy. So presumably, these autoantibodies also induce the problem in the repair system of the muscles and induce also some atrophy, which is some of the feature of this disease. And to complete the story, my very good friend Olivier Boyer, who is an immunologist in Rouen, did the in vivo part of the story, and he transferred passively the antibodies coming once again from plasmapheresis to the mice. And he can observe after 7 days of transfer of anti-SRP or anti-HMGCR that the strength of the mice is lower, is weaker if you have the antibodies, and also that this transfer induce some necrotic fibers, as you can see here in SRP or HMGCR transfected mice. If you did the same in some mice with no immunological system, with no lymphocytes, no T cells, no B cells, then you can maintain your system for much longer because the mice are not capable to mount one humoral response against human origin proteins. And then you maintain the weakness of the mice. And once again, you can observe some necrotic fibers and also some deposits of complement C5b9 on the muscle fibers of the mice. And finally, if we did the same experiments in mice with complement or mice without complements, cow for the system of the complement, then you restore the strength of the mice if they don't have any complement system, if you inject anti-SRP or anti-HMGCR. So that makes that at the end of the day, it is a situation in immune-mediated necrotizing myopathies with anti-SRP or anti-HMGCR, very similar to what we can observe during myasthenia gravis, where I remind you that you can have some autoantibodies which can recognize the end plates, activate the complement system, and then now one anti-complement strategy with eculizumab can ameliorate clearly the clinic of the myasthenic patients. That makes that one clinical trial will start at the very beginning of 2020 using one other anti-complement, which is the name, the ziloquiplan, for immune-mediated necrotizing myopathies. So I move now to the dermatomyositis subgroup with all these auto-antibodies. And Steve Greenberg was the first to show by RNA-seq strategy that compared dermatomyositis muscles to healthy donors muscles, you can observe mRNAs activations of a lot of cascade of mRNA and proteins linked to the system defense against viruses, which is the interferon type 1 pathway. We have in every cells a lot of sensors and proteins which can recognize the virus and which can activate the synthesis of interferon type 1 alpha or beta, which are a good mechanism of defense against these viruses. This is the case at the mRNA levels, but also at the protein levels, since in dermatomyositis patients, you can see all these proteins overexpressions, which are linked to this interferon pathway. And a good manner to block the interferon pathway is to use some monoclonal antibody against the interferon itself, but it's difficult because you have a lot of different subgroups of interferon alpha, 13 subgroups in fact. And you can block the receptor of interferon with a monoclonal antibody, or you can block the Janus kinase below the receptor using one JAK inhibits, one JAK1 or JAK2 inhibits. This JAK1 and 2 can block a lot of receptors, as you know. So Leandro he's a postdoc, and he did in the lab this kind of experiments. Once again, it is our in vitro system. And if you had some activator of the interferon pathway, poly-IC or interferon itself, then clearly you can block the myoblast fusions. You can also induce atrophy of the myotubes. And if you add one JAK inhibits in your culture, when you add one interferon type 1 beta here, and the JAK inhibits is the ruxolitinib, then you restore the phenotype of your cells. And we did the same in patients, very refractory patients, where we try all what we can use in our practice: corticosteroids, IVIG, methotrexate, azathioprine, cyclophosphamide, and so on and so forth. And all these ladies were totally refractory to the classical treatments. And we just add one JAK inhibits, and in few weeks, we can observe clearly one improvement of the skin lesions, but also of the muscle strength. So you can see here the C-DAISY, which is a composite score of skin lesions with a clear improvement in 3 months, and the interferon signature within the peripheral blood also almost normalized. So dermatomyositis are clearly one interferonopathies. To finish, we will move to inclusion body myositis. I don't have enough time to develop AntiSynthetase, sorry. And to make a long story short, there were a lot of debates regarding the physiopathogenesis of this kind of conditions, with some degenerative features within the muscles of the patients with these rim vacuoles, but also a lot of inflammatory infiltrates. And for instance, we published recently the fact that there are some very activated and differentiated CD8 T cells, cytotoxic T cells, and with using some markers, and once again, some unsupervised approach using 14 different markers of the lymphocytes, and using the CTOF technology, permitting that. And by unsupervised approach, we can observe clearly that some CD8 cells are really different than in other myositis. Here you can have some dermatomyositis, immune-mediated necrotizing myopathies, and AntiSynthetase. And these cells are, for instance, CD8 positive, Tibet positive, and this is cells which are called TEMRA cells, highly differentiated, terminally differentiated cells. For instance, the one we can observe during a chronic viral infections such as HIV infection. And Steve Greenberg also described some marker of these CD8 cells, which are KLRG1 protein at the surface of these CD8 cells. And we propose the following mechanism in the pathogenesis of IBM. These TEMRA cells, which are very resistant to corticosteroids and classical immunosuppressants, secrete a lot of cytotoxic enzymes such as granzyme and perforins, which induce some hole in the membrane and induce necrosis, but also endoplasmic reticulum stress. And also a lot of interferon, not type 1, but type 2, interferon gamma, which can induce some mitochondrial dysfunction, but also endoplasmic reticulum stress, overexpression of the IMASHI class 1, which is one of the hallmark of IBM. And all this accumulation of proteins are not well degraded by the endoplasmic, by the autophagy or the proteasome. And then you have these autophagy vacuoles, which are the rim vacuoles with unfolded and misfolded protein aggregates. So this is our view of the physiopathogenesis. And we published some years ago with David Elton-Jones from Oxford this long-term observational study on IBM, because I was surprised visiting David in England that IBM patients didn't receive any immunosuppressive drugs. Instead, in Paris, because it is one inflammatory myopathies, then we treated our patients with a lot of corticosteroids plus methotrexate or IVIG. So at the end of the day, we perform a clinic for our patients, and we compare our patients. It was not a prospective trials. We were not here at the very beginning of the story, and where at the moment where we started the treatment or no treatment. So it's not a trials with corticosteroids against placebo, of course. But we review all the patients and we observe on 2 scale of handicap, the Walton and the RMI, but also on the IBM Weakness Composite Index, which is a score on the muscle strength and endurance of the patients, that the treated patients have a more severe handicap and are weaker than the untreated ones. So since that time in Paris, we stopped to treat our patients with corticosteroids, maybe because it may induce one corticosteroid myopathy, in addition to IBM. And furthermore, we know now that the TEMRA cells, the CD8, highly differentiated CD8 cells, are perfectly resistant to corticosteroids. And to make a long story short, we use rapamycin, Sirolimus, because it's the only drug which permits to increase the longevity of mice by increasing the autophagy. And in models of Alzheimer's disease in mice, it can permit also to increase the memory score of the mice. And rapamycin is used to prevent kidney rejection after kidney graft, because it's one immunosuppressant active on TEMRA cells and preserving also Treg cells, which are decreased in IBM patients. So that makes that we made one randomized controlled monocentric trials with 22 patients treated by rapamycin during 1 year and 22 with the placebo. And after 1 year, you can see that we can't see any difference in the rapamycin group in terms of 6-minute walking distance. And as expected, we can observe one decrease of the distance in the placebo group. We have the same kind of things regarding the HAQ, which is a marker of handicap, which increased a little bit in the placebo group and which remains stable in the rapamycin. And by quantitative MRI, we can observe more fatty replacements in some muscles with the placebo, and it remains stable in the quadriceps. So my conclusion is that really you should use these different biomarkers, auto-antibodies, to help you to perform the diagnosis and the good classification of the patients. Once again, it's not expensive. It's easy to obtain. In a few days, you have your answer. And if you have a very typical phenotype and one of those auto-antibodies, then I think it's maybe not totally mandatory to perform the muscle biopsy. If you have the lung involvement, arthralgia, the weakness, high CK level, and anti-G1, it's one antisynthetase syndrome. Of course, if you don't have these auto-antibodies, and it's not always the case, in 1/3 of the patients don't have any of these auto-antibodies, you need to perform the muscle biopsy. Today, we are still stuck in the classical treatments for dermatomyositis, overlap myositis, and immune-mediated necrotizing myopathies with those corticosteroids at high dose during the first months, 1 milligram per kilo per day, plus one sparing agent such as methotrexate. And if your guy is very severe, you can add IVIG. Severe means with swallowing troubles or loss of walking capabilities. And we need we really need some large controlled trials to test different immunosuppressive drugs or JAK inhibitors and so on and so forth. And for instance, rituximab is maybe more effective in anti-G1, anti-MI2, and anti-SRP patients compared to the others. But tomorrow, I hope I have convinced you that tomorrow we will certainly use for dermatomyositis, because it is one interferonopathy, we will use some JAK inhibitors, and some trials are ongoing or just started right now. For immune-mediated necrotizing myopathies, you can have two kinds of strategy. You can delete the B cells secreting the anti-SRP or the anti-HMGCR, or you can have some anti-complement strategies. For inclusion body myositis, we can have tomorrow, I hope, because we are reproducing the trial in the second independent cohort of patients, we will have the rapamycin or maybe some strategy against the TEMRA cells. And for overlap myositis, the main problem is the lung, so we have to use some drug effective for to tackle the interstitial lung disease. So that's it. Thank you very much for your attention. This is the team at the lab, and we have a lot of different subjects. If some of you are interested, just send me an email. Thank you.